So unmute, please.
Okay. Yeah. Thanks, Subhranshu and Rajiv, for giving platform today to speak on post-HTO high tibial osteotomy TKR conversions. I'll just present 2 or 3 small cases to walk us through on this. So, different studies, obviously, we know of the couple of them say comparable to primary TKR, a couple of them say inferior, but the baseline is it is technically more challenging. I would call it a complex primary conversion with a variety of challenges that come across when you have these high tibial osteotomy conversions. First, as already mentioned by a couple of my previous speakers, you have multiple scars because obviously you have an implant inside in this, and lateral most scar to be taken off. For lateral scars in a closing bed osteotomy, normally they're not an issue. We give a small stab, take out the staple, and proceed with it. For medial scars, again, you can move on. But the whole point to remember is there should be at least 2 to 5 to 3 centimeter of gap if you want to use a parallel incision. And if you are joining the incision, it has to be at 50 to 60 degrees angle. You get a variety of types: coventry closing wedge, infratubercle osteotomy, Mackett dome osteotomy, medial opening wedge osteotomy. And all of these would have a different approach in couple of times to proceed forward because the technicalities are at times different. With the different kind of implants, you can always choose whether you are going to go in for a single stage or you want to have 2 stages. And a couple of times when we have plates put in, we do this procedure in 2 stages. We take out the plates first and then subsequently take it for TKR. In all other cases where there is a staple or K-wires or just screws, it's a single stage. So the first case is 65-year-old lady, 8 years post high tibial osteotomy. This is the AP and lateral views, and as rightly mentioned through, we know that is a hyper-corrected lateral closing wedge osteotomy, valgus joint line, and patella baha on the way, stiffness of the patella that you're going to go through. And this is the lateral wedge. If you see, this is the kind of cut that you're going to have through. You have a valgus remodeling of tibia already developed through. You go on the lateral sagittal side also, there is a translation. There is a downward or an anterior slope of tibia. I don't know how you felt through, but whenever we have seen these conversions, we have seen that in all these high tibial osteotomies where you have a closing wedge osteotomy, we normally find anterior slopes. In all those medial opening wedge osteotomies, we normally find enhanced posterior slope. So there is majority of times a patella baha in all these cases because of the contracture of the extensor apparatus. And everting the patella is always a problem. Exposing the lateral side is an issue. Whatever it is, you have to protect a avulsion of patellar tendon. You can always put a pin at the tibial tubercle. My threshold for using quadriceps snip in these cases would be very, very low. Hardly ever we require a tibial tubercle osteotomy in these HTO conversions. So in these cases, the point to remember, as I said through, was the anterior slope of tibia. So if you cut too much of tibia, what you have is a huge flexion gap. So be very, very meticulous. You don't want to cut too much of the tibia at the back. You want to restore equal flexion extension gaps. As Anup also mentioned, for addressing all these patella bahas, you resect less of distal femur and superiorize the patellar component. This would walk you off majority of these deformities. In cases where we have defects, we normally try to bypass them with extension rods and get across this situation. Now, the second case that we have through is 58-year-old female, operated case of high tibial osteotomy, lateral closing wedge osteotomy 7 years back with LC fixation. It was done somewhere else. I didn't have the record of that. And anterior midline incision was there. Subsequent implant removal was done 1 year back, and now she presented with pain and disability. So this is an undercorrected varus deformity, plates already moved, scar taken off, posterior slope of tibia, patella baha is majority of times there in all these deformities. As we can say, if you try to align the mechanical axis, you have an agitated varus deformity in these cases. So the point again is approach, which again is a midline approach as has already been used. The tibial cut, we know in these cases, we'll have a bigger lateral side and thinner medial side. The slope of the tibia is very, very important to look in. You don't want to give too much of the slope. 0 to 3 degrees is good enough. The tibial component design, you normally do not require stems in these cases. And patella tracking, again, how do you circumvent the patella baha is the same philosophy. As you rightly see in this case, these kind of lateral scars are normally not an issue. So this is the post-op structure of this case. A third and small case is This 51-year-old female post HTO 39 months back. Now, this is a typical kind of session where you have an abrupt change in the lateral tibial flare. This is where your positioning of the tibial component is going to be a big issue. As you rightly see, in this case, we have a posterior slope of tibia, patella baja is there, inside severity ratio is less than 1. There is an altered mediolateral slope. This is an intra-articular correction of extra-articular deformity. You want to centralize the stem. But in all these closing edge osteotomies where there is a change in the flare of lateral tibial cortex, you have to be very, very concerned for the relative position of the medullary canal. If you use a conventional tibial platform, you are going to hit on to the lateral cortex. So that's where you need to calculate your angles, calculate your positions. Certain tricks to handle across this is you medialize the tibial stem, just undersize the middle, tibial tray. You will have a certain amount of under coverage on the lateral side, and you can still prevent not perforating the lateral cortex. Now, this medialization of tibial stem helps, but in a lot of cases, you don't have a choice and you have to go with these kind of offset stems. You have taken out the staple through a lateral incision, and these are the kind of offset keels that you can use to circumvent these diseases, or in case of defects, you can use an offset stem. So you have to remember, if you use a conventional tray and you're hitting the lateral cortex, you might perforate it off. So a post HTO TKR offset is definitely a consideration in these kind of cases, and you need to have a medialized positioning of your tibial tray. But excessive medialization is also a problem because you do not want to hamper the patellofemoral tracking. So the trick to handle this is you should calculate the tibial flare index. It's a ratio. You take the distance across the maximum width of the tibia, which is point A. You draw a vertical line from the lateral flare, and this calculation is B. So A on B, the moment it is less, tibial flare is less than 2.5, you have to anticipate difficulty in tibial tray placement. As you see pictures like this, where the tray placement is definitely going to be a hindrance, and you need to have your medial offsets along with you on table. So the points to remember in a HTO conversion is it's a difficulty in placement of tibial components. The exposures are tough, A, because of the scar, B, because you have a sort of scarring on the lateral side, patellar adhesions and patella baja that you need to take care not to worsen the patellar tendon. Preferably implants should be removed before TKR. If there are plates like these, we take two separate surgeries. For all staples, it's a single stage. Possibility of subacute infection does always remain on, and intraoperative frozen section or gum staining is something that you can keep on if you need to change it to a two-stage revision. So to summarize, a successful total knee after HTO is technically more challenging. You need to take care of your exposure part. SNP normally helps you. You have to try to subluxate the patella, not try to evert, because you have to prevent the avulsion of it. Preoperative tabulating and calculation is really very helpful. And more than 5 mm medialization of tibial component should be avoided due to high risk of subluxation or dislocation of patella and bad patellofemoral dynamics. So in those cases where you require too much of medialization, the idea is you should have offset stems with you on table. So in all these cases, as we have been seeing with all these extra articular deformity corrections, our planning is very, very important. If we fail to plan, our plan is going to fail. Thank you so much, and I'm more than happy to answer any questions that you get across on this topic.
It's a wonderfully explained variety of high tibial osteotomy, and it is rightly said that all the knees post osteotomy cannot be labeled as in one group. It depends upon how the osteotomy was done, what is the level of stiffness, what is the level of correction or overcorrection, and what is the level of what is the situation of the scarring. I think it's very well explained, and rightly said that you have to have an offset stem ready, especially in post HTO cases. I think it's very well done. Dr. Briard has been dealing with many cases of post osteotomy. John V, what's your opinion about the post high tibial osteotomy total knee arthroplasty? Do you think that the results will be same, or do you tell your patients that results may not be the same as the normal knee? And Manuj, you also can answer this. Yeah.
Infection is a problem. So I think it's when the healing was not straightforward. I think you have to do it in 2 stages. I think you are right. That's very important. I think closing wedge and opening wedge are different. I think closing wedge, we have the problem, and we need to have offset stem sometimes, so we have to be ready, but planning is very important. And medial opening wedge, it's much easier. I think now we see mostly opening wedge. Well, they are much better done now. I think we don't see huge overcorrection with a staple as we used to see. I think now revision of HTO is more simple. But I think when you look at the literatures, people are saying that's, well, it's like a primary knee. I don't think so. I think we have more complications, skin complication, more infection. And so it's not like a typical simple primary knee, but now we are asking more. We want better results. And I think so we have to be very careful to what we can promise to our patient, and the risk of complication, especially if you have comorbidities.
Thank you, Janvi. Manuj, what's your, do you tell your patients anything different in the results, the expectation for results in post HTO cases?
Rajiv, for all of us, I believe sitting on this dais, we all have done far less of these HTOs per se. What we do is HTO done by somebody else. My problem is that when we look at majority of high tibial osteotomies, they are not done the right way. Either they are